welcome to this episode of A Cancer Conversation with the Georgia Cancer Center at Augusta University. As always, not always, almost always, I am your host, Chris Curry, and I am the Communications and Marketing Manager here at the Georgia Cancer Center. I want to thank you all for watching, listening to this podcast episode. Today, we are going to be talking about neuroendocrine tumors, and joining us, we have two very special guests. First, on my far right is Dr. Stephen Calhoun. Dr. Calhoun is a professor of surgical oncology here at the Georgia Cancer Center and Medical College of Georgia at Augusta University at AU, and he treats patients with neuroendocrine tumors and has a wealth of knowledge to share about them. So I want to thank you, Dr. Calhoun, for joining me.
Thanks for the opportunity.
Absolutely. And also joining us is one of Dr. Calhoun's patients. This is Linda Biller here on my right. We are honored to have Linda spending time with us today for a cancer conversation. She'll be sharing her story, her experience with a neuroendocrine tumor. So Linda, I want to say thank you very much for sitting down with us and being a part of this conversation.
Thank you for having me. I appreciate it.
Absolutely. So Dr. Calhoun, we're going to start with you because I always try to give our physicians an opportunity to share a little bit about themselves before we really dive into the topic. Obviously, this is a podcast, so we have some time to really dive into the topic, but I always like starting to learn about the guest that I have. So my question for you is sort of, what was your career path to land in cancer care, cancer research, neuroendocrine tumors, et cetera?
So going to medical school was just a way of consolidating interests in biology and science, and that led me into surgery. And as a part of my surgical training, there was a requirement to do research, and I ended up doing research in cancer and doing a fellowship in surgical oncology. And then ultimately I did a second fellowship in liver and multi-organ transplant. So I spent a bulk of my career doing liver surgery in the sense of liver transplantation, which then brings me back to patients with neuroendocrine tumors because many of them end up with disease in their liver. Mm-hmm. And I happened to be at a high volume program in Los Angeles before moving here, where we saw probably close to 2,000 patients.
Oh, wow.
With neuroendocrine, because everyone has a relative in LA, I guess.
Yeah,
we ended
absolutely.
up seeing a lot of patients. But coming here was a great opportunity to not be in Los Angeles.
Yes, Augusta is largely different than Los Angeles, for sure.
And I appreciate that. Closer to family now here.
Okay, that's always good.
And wonderful people and the climate. But one of the first things I noticed was an abundance of patients with neuroendocrine tumors. So then that's why we're here today.
Yeah, absolutely. So Linda, you are a neuroendocrine tumor patient, survivor. Talk to me about when you were first diagnosed and what that process was like, because we were talking before we started recording that it was quite the journey for you to be diagnosed with a neuroendocrine tumor or an NET.
It was. I was actually diagnosed in March of 2023.
Okay.
With because they thought I just had a bowel obstruction.
Okay.
A full bowel obstruction.
Okay.
When it actually was partial, but there was a tumor on the mesentery.
Oh, wow.
That caused the obstruction.
Okay.
But it had been there for probably since 2013.
Okay, so 2023, 2013, that's right. 10 years.
That's 10 years. Well, 2018, I was done a PET scan. Had a PET scan because they thought I might have lymphoma because of numbers.
Okay.
Blood numbers, and it turned out that they found the tumor. They just didn't tell me or do anything about it.
Okay.
Another place, not the Georgia Cancer Center.
Okay.
So it just happened to be, I just happened to take my husband to the emergency room, and I got sick while I was there.
In 2023.
In 2023.
Okay.
And a doctor there happened to be from Fort Eisenhower or Fort Gordon.
Okay.
And he happened to look at it and knew right away that it was a NET tumor.
Okay. And Dr. Calhoun, you were saying that sort of a decades-long experience or situation like Linda's is more common than not in neuroendocrine tumor patients?
Unfortunately, in healthcare and maybe in other realms, there's a saying that when you hear hoofbeats, you think of horses because those are more common. And this is a zebra. In fact, patients with neuroendocrine tumors have organizations of support that usually reference zebra because they kind of use that name. So most physicians, because this is a rare tumor, they don't encounter anyone with a neuroendocrine tumor, maybe over their entire career. And the symptoms that people present with are pretty vague and nonspecific, and they're not thinking of zebras. But you would have to think of it to pursue the kind of blood tests and imaging and so forth that would make the diagnosis earlier. So it's super common for patients to have years of symptoms and visits to doctors before someone finally gets a scan and thinks about it. And by then, often it's spread to the liver and other areas, which doesn't make it unmanageable, but it leads to another problem of kind of over-interpreting the health of the patient, that they've got disease in their liver now and maybe nothing can be done, and there's kind of a fatalistic attitude that really is inappropriate. So there's been a lot of progress in the last 10 or 15 years that I've been involved, and so many treatment options now and so many things that can be done. And patients do well for a long time after the diagnosis, but it would still be nice to get the word out
Absolutely.
to doctors and patients who might be having symptoms. And because I've had patients say, I think I have a neuroendocrine tumor, just because they were looking on the internet and they were figuring out what their symptoms were. And they took that to the doctor. If you can imagine, it comes from the patient.
So what was it like for you, Linda, to finally get that answer? Because we're talking 10 years. I can imagine there was a lot of frustration and anger and everything.
Actually, fear I think was my biggest thing, and because I had a mother who passed away from cancer, a sister who passed away from cancer. Theirs were, of course, not neuroendocrine, but there's just a big fear to know that this has been there for and anger too, because it's been there for so long, and you don't know about it. And I think that's the biggest fear. And then not realizing the type of surgeries, what the surgery's going to do, how it's going to feel after your surgery, and the steps, and you really have to face your mortality at that point. Because you don't know.
And Dr. Calhoun, what do the tests look like for determining if someone has an NET, a neuroendocrine tumor, and then what do the treatments look like for those patients?
So it depends on where the patient is in terms of their disease, where it is, where it may have evolved or spread to, which is not uncommon. And it in defense of doctors and the frustration that patients feel, there are probably 12 or 13 different ways to categorize neuroendocrine tumors. In fact, neuroendocrine is just one name. So there are multiple names. And some of the tumors are what we call functional. They make hormones. So some patients have no obvious disease at all if you were to scan them, yet they have massive symptoms from the hormones made by the tumor. Other patients have amazing, huge amounts of disease and almost no symptoms. So it's super frustrating for physicians as well.
That does sound very frustrating.
But to answer your question, there are some very specific blood tests that we get, and they're not on any normal panels, so someone would have to think of this diagnosis in order to order the special tests, which usually have to get sent out to a lab far away. And in terms of the treatments, it depends on where it is exactly, what organs are involved, where it started. Some start in the intestines. Others may start in the pancreas. They can start in the lung. The most common start in the abdominal cavity, in the intestines or the pancreas.
What is it that makes them start in those different places?
Yeah, we don't know. And that's one of the big ticket questions that we're very interested in. And actually, we can talk now or later, but we're reviewing the national data here with some of the research facilities that we have.
Yeah, we can
and
talk
we're
about
just
it now.
about to publish a manuscript that is reviewing national data for for the incidence and prevalence of neuroendocrine tumors. And guess what?
What?
Georgia is a hot spot.
Really?
Wow.
So that's why when I walked in the door, I was encountering patients like you that have this disease, because there are a lot here for whatever reason.
And we don't know
and
why.
It kind of gets to your question: is there an environmental, factor or something? So we're working on that, and it interestingly enough, when you look around and talk to people here in the cancer center, there are some people doing basic science research in neuroendocrine tumors. So one of our interests in setting up a special center for neuroendocrine tumor treatment is to consolidate all of the treatment options and research opportunities, and to have some a multidisciplinary consolidated effort for optimizing treatment for patients who are very complicated. Would you consider yourself complicated?
I think I would.
Yeah, I think that's
I
fair.
would.
Why do you consider yourself complicated?
Well, because there's so many different things that I have had happen to me since 2013. I had to have a spleen removed because of a cyst. Well, because of the symptoms that I showed, was it an incidental finding, or was it because the tumor was already there?
Yeah.
We don't know.
Okay.
And just different things. I mean, I'm just saying, I consider myself in very good health, but when you look at my medical record, I'm not in good health at all. I've got a lot of different things, but is it because the neuroendocrine sat there for so long that it wasn't found?
Yeah.
That it just wasn't treated? I mean, I do have to say that I did have a hematologist at another facility that was looking. He knew there was something because of the blood work, but he could not find it. He couldn't, and I guess neuroendocrine never crossed their minds. So
Gets back to ordering exactly the right tests in order to uncover that diagnosis.
Why? What is it about neuroendocrine tumors that makes them so hard to detect or find? I mean, I think breast cancer, we have a mammogram that does the mammogramming of it and finds the mass. We have lung screening. We have other tests that specifically point to different types of cancer. But what is it about neuroendocrine tumors? Do we know why they're so hard to detect?
Well, the difficulty is in considering the diagnosis and then ordering the right test. So they are rare. They're zebras. So most doctors aren't thinking of it. Everybody with indigestion doesn't have a neuroendocrine tumor.
Right.
But most patients with neuroendocrine tumors may have symptoms that sound like indigestion. So they're so nonspecific that most patients get treated like they have an irritable bowel or whatever for years. They carry a diagnosis and a treatment for something that in retrospect they never had.
Yeah.
It's really this. So it's one of those things you have to think of it first before you can get the right test. There's no one test that could screen patients for this. It's one of those things that we need to raise awareness and put it on people's minds, so that patients and doctors, so that we can, get to the right conclusion. There are some fancier tests, which we also have here at Augusta University, fancy PET scans that are specific to neuroendocrine, but you can't order that without already knowing what it is. And at that point, you're just proving it and looking for the extent of the disease. So, because the healthcare dollars don't want to pay for a very expensive test just to kind of what if and look, for screening.
How frustrating is it for you to see patients like Linda who have been, and not necessarily frustration with their doctors, but just frustration with the disease itself, to see patients like Linda go through years of testing and medications and treatments and, finally we found a neuroendocrine tumor and that's what it is, or what it...
It's frustrating, but I think the most frustrating aspect is, I'm seeing the probably the tip of the iceberg of patients who have the sophistication to follow up and pursue some expert opinions. I think a lot of patients are out there that are never diagnosed, or when they're diagnosed, they're told nothing can be done because of the ignorance, unfortunately, of the healthcare providers that they encounter. Because it's an uncommon thing, they just don't know much about it, and they make assumptions, and that's why having a specialized center, a neuroendocrine tumor center, like the one we're putting together here, can be a referral, a place of referral for doctors and patients. When I talked about all the patients we'd seen at the place I came from in LA, I think it was at least 1,500, almost every single one of them had referred themselves.
Okay.
Never a doctor referred them. The
Okay.
patients went online, figured out where people are interested in treating this disease, and they called us up and referred themselves, if you can imagine that.
Oh, wow.
So yeah, it's frustrating, just and again, in defense of doctors and the healthcare industry, it's a disease that's evolved, and so the names that we use and the classifications change every couple of years.
What are some of the more common names or classifications that people may search for if they're doing a Google search?
So carcinoid, carcinoid disease, carcinoid syndrome, neuroendocrine tumor, neuroendocrine neoplasia. There are certain types of neuroendocrine tumors that start in the pancreas, and so those may be labeled as a pancreatic cancer, but even though they're a malignancy and they're starting in the pancreas, they're kind of not the usual thing that you think of when you think of pancreatic cancer.
Okay.
Think of Steve Jobs.
Yeah.
So I don't know if I'm answering your question.
No,
or not.
you are.
Yeah.
You are.
But-
I think people are always hungry for information. They're looking for answers, and if doing a search, finding information may lead them to someone like yourself that can help them. I think that's very important, and so I want people to be aware of what they should be looking for, because, like you said, the symptoms of a neuroendocrine tumor are very nonspecific. So what are some other things that people should be looking for if they think they may have an NET?
Yeah, so those are the main names.
Okay.
It gets kind of into the weeds after that, but I think most people would have encountered something, a website with some information. There's, as you can imagine, with all the people out there, as frustrated as this group might be, they start their own groups.
Okay.
And so there are a lot of online resources for patients to tap into, and I happen to be on a national neuroendocrine tumor board, for example, that exists to try to consolidate expertise from smaller programs that may have a patient that they're confused by, and what do the experts say we should do next, and so forth. And I think I might have said earlier, but we're starting a patient support group here as well.
One
so
of the
that
biggest thing that I'm sorry.
Yeah, no.
One of the biggest thing that I've noticed, because I'm on a zebra support group, and they're looking for NET specialists, because regular cancer doctors or oncologists don't necessarily look for the NETs.
Right.
So they're looking. A lot of people are looking for NET specialists, and that's a big thing.
What sort of researcher information did you look for during that 10-year span to before you found out that it was a neuroendocrine tumor? Like, what was your process like?
Actually, I had just had some, like I said, there's so many physical things that I had that I just accounted it to one of those.
Okay.
Because it was like when they removed the spleen, I was better for a while, and then I got sick again. And so when I research, I always look at the glasses half full.
Okay.
So I don't look for anything I try not to look for anything that is negative.
I gotcha.
So to be honest with you, I don't look for stuff. And
Okay.
I didn't look for stuff until I started getting worse. Then I started researching a little bit, but I never found found neuroendocrine tumors.
And what does it mean to be part of this support group that you just mentioned?
It's actually, you see a lot, you read a lot, and there's a lot of people out there that have the neuroendocrine tumors that are having a very hard time with it. Fortunately, mine are well differentiated, and there's such a difference. I'm assuming the difference is big between differentiated and poor differentiated and well differentiated. Mine is well differentiated,
Okay.
so I'm lucky
Okay.
that mine is in that aspect.
Okay.
But I learned about, because right now I'm on a Luthera therapy, radiation therapy, and I learned a lot about it from this support group because a lot of people have had it, and they have, most of them have get sick from it. So I was a little leery. I'm doing quite well with it.
That's
my
awesome.
body's doing really well with the radiation therapy.
We're very
so.
glad for you for that.
Yes, me too. Me too.
What is your treatment process? Talk a little bit about the medication, the radiation that you take.
Luthera is a IV infused radiation.
Okay.
It's an all day process they have all these nuclear medicine people. I think there's like 8 or 9 that come in the room at the same time and infuse it by IV.
Okay.
And then you can't be around people within so many feet of people for so many days.
Okay.
Everything you do has to be, your clothes have to be washed every day. After I think it's 3 days, you have to throw away your toothbrushes. You can't use anything over again.
Wow.
You've got to certain things like, say, when you go to the bathroom, flush the toilet 3 times.
Okay.
After every time you go. So, and they want you to make sure that you drink a lot of fluids to get the radiation out of your system.
Okay.
And then
But it's gone okay, right?
Oh yes,
Oh,
great.
good, okay.
Yeah,
Good.
I'm doing
make
really,
it sound-
I'm doing really well
Yeah.
with it. I have the biggest problem I have is the injection.
Mm-hmm.
I think it's the lanatride.
Oh, yeah. So,
I think the injection is the problem that I
yeah.
have. 'Cause-
So the typical. So you started with surgery
right.
to remove it,
Yes.
the bulk of what we had, and then we kind of clean up with some other treatments.
Okay.
One of the most common used drugs. It's not really a chemotherapy, but it's a treatment that kind of turns off some of the hormone production and
Okay.
can slow tumor growth, and that's a monthly injection that people get in their butt. So that's really literally a pain in the butt.
Yes, it is.
Yes.
And then there's a number of other treatment options depending on the circumstance. But the Lutathera is quite remarkable because the scans we use, the PET scans, have a tracer that goes to the tumor and lights it up so we can see exactly where the tumor is and isn't.
Okay.
And then this treatment uses the same little receptor, but now puts on a higher energy radiation source. So patients they get an infusion, it just goes right to the tumor, wherever the tumor is, and only to the tumor,
Okay.
and kills it. It's kind of like a magic bullet, that we've been waiting for, in lots of areas of cancer care.
Is this type of radiation, this infusion radiation that you all are talking about, is this for all types of NETs for neuroendocrine tumors, or is it only for certain types? Because we talked earlier that the NETs can start in different parts of the body. So are there different targeted treatments for different parts of the body, or is this Lutathera the one for all of them?
Yeah, so it's not for all, but for a lot, it may be an option. Again, it's one of I like to think, since we're in Augusta, we got a bag of clubs.
Yes, golf.
And we have to
Masters,
pick
yes.
the right club,
Yes.
depending on where the ball's lying, right? So it's one of the many treatment options we have. And it's not for everyone. It's not always true that the ball's where you want it to use that club. It has to light up with that special PET scan.
Okay.
Otherwise, it's not going to work. As you can imagine, it's not going to go where we want it to. But oftentimes, it is one of the treatment options that can be used along with a number of other treatments in treating patients with this disease. We all go to the doctor, and we rely on, all of us go to the doctor, and we rely on them and their opinion and their expertise to take care of our health. And with some of the non-specific kind of vague symptoms that most patients have early on, at least, there's no way to know or to even always think of it. I have had a number of patients who have been frustrated to the point where I don't know how, but they tumbled upon the possibility and then looked it up and then decided that is what I have.
Okay.
And ultimately, went to wherever. But another point to be made is, as a physician, when you take care of neuroendocrine patients, you have to be really prepared because most of them end up knowing more than the doctor because they do their homework.
Yes.
It's not uncommon to have a patient come in with a big 3-ring binder
Okay.
of all their test results and their whole history, and because they're keeping track, and they want to get this problem, tackled.
And what is it like for you to be an advocate now for newly diagnosed or even just other NET patients that you interact with?
I think it's you just want to make sure they have the information that you didn't have, because you didn't, I went so long without knowing that it's you just want to make sure people know that there is treatments. It's not a necessarily an end of life situation. Right. There is a lot of, you can have a very long life after having an neuroendocrine tumor. And so you want to use the positive of that.
Yeah. And what does it mean to have someone like him and the center, the team that he is working to put together? What does it mean to have someone like him and this team and this center once it gets up and running so close to home?
It's actually it makes you very, it gives me, well, how do I say that? It makes me very happy to have that, because we know that in this case, it'll be someone that we know will be here, and we don't have, some people have to travel for hours and hours to get to places. I don't even know, I think is there even a NET specialist near Atlanta?
Not at the moment.
I didn't think
Yeah.
so. So, I mean, some places people have to go to different states, like you said. So it will be very nice to have someone in this area. And I'm sure that every person that has a NET will be very glad that he's here. That the center will be here eventually. It should be good.
If you can imagine not feeling well, having a health problem, and then on top of that having to travel. I mean, we not uncommonly had patients come from other countries in all 50 states, and that's changing now because there's more expertise and interest and awareness. But I think it's definitely a service to Georgia and surrounding areas that hasn't been there before. And
so you talk about the research that you're doing, you're talking about being part of a national board. What about clinical trials, clinical research? What is the future of neuroendocrine tumor diagnosis and treatment and survival and all of those things? What does it look like?
It's very positive. In fact, when I first got started in this area, kind of inadvertently because of circumstances, we didn't know half of what we know now. And there have been a number of national trials over the years to get us to where we are now. And I think one of the advantages of having a center is being able to enroll patients in trials and participate in furthering the general cause of our knowledge. And the treatment options have evolved amazingly. I mean, we used to just have one drug and one scan, and now there's a number of drugs and ways to not just treat the tumor but the symptoms. And I think mainly there's an appreciation of the difference that neuroendocrine tumors present relative to other kinds of malignancies, and the options available for using surgery and other interventions, that some of which are pretty minimally invasive. And really, people can coexist with this disease. You may not cure it in the sense that every bit's gone and you never have to give it another scan or never worry about it again, but people can coexist with this for decades and with the right treatment and management.
And I was going to ask you, what has your life been like since being diagnosed in 2023? Are you still going on vacations and living with family and making memories and just living life?
I would like to do that eventually, but as I said, I was a caregiver for my husband, so that was the biggest thing. Before I could even start radiation, I had to find a place for him
Okay.
because he has a traumatic brain injury.
Okay.
So I had to find a living center for him to be
Okay.
while I did the radiation. So, but other than that, normally, I mean, my life is good. I feel good. I feel good, especially since I've had the injections and the even with the radiation. I feel good pretty much most of the time.
And how many injections and how many rounds of radiation have you had so far?
I've only had 2 rounds of radiation, and I've got 2 more expected.
Okay. And is that once a month?
No, 8 weeks apart.
8 weeks apart.
Mine are 8 weeks apart.
Okay.
I guess they do each as, whatever, however they have to do it.
Okay.
But mine are 8 weeks, so I have 2 more rounds.
And how often do you get the injections? The pain in the butt?
During the radiation, I get the injection after same day of the radiation at the end of the day. So right now I'm going on every 8 weeks, but before I was getting them every 28 days.
Okay.
And those are a pain.
But you can look forward to having those forever.
That's correct. I do get to have them forever. But I do have a very positive outlook with it from everything that I've read and researched. I mean, to me, I'm very lucky that this is if I had to have cancer, this is the type that if I have to have it, might as well be this one.
Do you have a strong social circle supporting you here in the area?
I have my children are very strong and supportive, but I've never been very out social like so.
Okay.
But I'm hoping once they do get the patient, the groups that I'll be able to be part of that.
And do you what do you tell people? Do you try to educate people that you talk to, that you come into contact with in your social circle about NETs and just being an advocate for your health? Because I feel like an NET patient has to be an advocate for their health.
You do, because like I said before, I did not even have a clue that I had possibly had cancer. Mm-hmm. But now it's like, it's not a normal everyday thing. Just like whenever I was talking about trying to get my husband in a center so I could get radiation, one of the people that actually was a social worker, not associated with Georgia Cancer Center, mm-hmm. that had specifically said, well, it's just radiation. Mm-hmm. It's no big deal. But because she's a cancer survivor, but she was talking about like the pinpoint radiation. And it's a big difference in that normal radiation. So some people don't understand that it's still a cancer, even though you're not doing the same treatments. And that's your outlook. To me, your outlook is better than in most cancers. Well, mine is, fortunately.
Yeah.
So.
That's true.
But I know I didn't answer the question. But.
No, that was a great answer. Because I think the reason that I asked that question is, and the reason that I ask about the future of cancer care is not necessarily curing the cancer. We've talked about that, but finding ways to turn cancer into a chronic condition that people can live with and thrive with by taking a pill or 2 pills or getting a monthly injection. I mean, that's really what I have understood the future of cancer care and treatment to look like, is people are living perfectly normal lives. They're taking their medication however often they're supposed to take it for their type of cancer, but they're still doing their thing. They're not having to stop.
Exactly. And that's exactly describes the circumstance for most patients with neuroendocrine tumors. Once they're tuned in and managed well, then it's not the focus of their entire existence. They can kind of move on with life. Yeah,
you think about other things instead of you don't think of the cancer every day. I mean, on the website, so the Zebra website that I'm on, there's a lot of people that have poor differentiated, and some people have nets that are completely removed. They don't have to have any follow-up. Okay. Others have the metastatic and so it just depends on what it is. But if there's a lot of people that I've seen that have it's so they're they look at all the negatives of it, which I guess that's the way that, you know, if mine was poorly differentiated, I'd probably look at it a little differently too.
Yeah.
But I do feel very lucky that the way how my treatments and everything have gone, and Dr. Calhoun and even Dr. Nyack here have been wonderful. You know, I would suggest anyone come to them because I think it's been great.
Well, we appreciate you so much for sitting down, and Dr. Calhoun, thank you for joining us. And
Yeah, thank you.
Oh, thank you.
I'm always honored to interview survivors and hear their story and hear their experiences and share those with other people, because I think it's so powerful. Even though cancer can be very individualized these days, I still think it's very powerful to hear from survivors that there's hope, there's life, you know, after cancer or during your treatment or whatever. So thank you very much for sitting down with us today.
Well, thank you. I appreciate it very much.
And Dr.
Thank
Calhoun,
you.
thank you as always.
Okay.
I'm sure we will do many more episodes
Okay.
in the coming months and years. So
All right.
thank you very much.
We'll get it done.
Absolutely.
All right, thanks.
Thank you for watching or listening to A Cancer Conversation with the Georgia Cancer Center at Augusta University. And please, if you have any questions about neuroendocrine tumors, you can send us an email. That email is cancer@augusta.edu. We will definitely share those questions with Dr. Calhoun or Linda. If you have a question for her, we can get in touch with her, obviously, and share your questions with her and get you those answers. And remember to like, subscribe, follow A Cancer Conversation wherever you get your podcast, and we will see you next time.